Welcome to today's webinar, the second in our four-part series, Understanding Addiction and Supporting Recovery, presented by the Clergy Education and Training Project of NACOA, the National Association for Children of Alcoholics. Today we will be looking at the opioid epidemic that is devastating so many of our communities. And today is also the International Opioid Awareness Day. While we all know the greatest killer drug in America is alcohol, 88,000 just last year, alcoholism, however, is quiet, slow, insidious, slowly entering our families and eating it away at all the family members in ways that are deceptive and, and confusing, leading to chronic emotional stress. The opioid heroin addiction epidemic has been dramatic, crashing into our communities and families and creating a growing demand for halting the devastation and for developing strategies for both preventing it and for intervening on and treating it wherever possible. All of us have a responsibility to support and be part of the efforts to do just that, including the faith community. But first we need to understand its nature and pathways. My name is Sis Wenger, and I am the President and CEO of NACOA, your host for this webinar series. The series is co-sponsored by the Association for Clinical Pastoral Education, the American Association of Pastoral Counselors, the National Council on Alcoholism and Drug Dependency, and the National Alliance for Drug-Endangered Children. The entire series is supported by SAMHSA, the Substance Abuse and Mental Health Services Administration. Last week's webinar applied the concepts of screening and brief interventions to the legitimate role of the faith community in helping to prevent addiction and support recovery. Today we look at how the opiate epidemic continues to impact families of all sizes, races, economic status, and ethnic groups around the country, either personally or through friends, classmates, and co-workers, neighbors, or fellow members of our congregations. All could benefit from a knowledgeable and supportive place of worship for support, and today we continue that discussion. We are extremely pleased to have Dr. William S. Jacobs as our presenter today. He is a board-certified in anesthesiology, pain medicine, and addiction medicine, a Phi Beta Kappa magna cum laude University of Georgia undergraduate, and a graduate of the Medical College of Georgia. Dr. Jacobs did his anesthesiology residency at the University of Alabama, Birmingham, before matriculating to the University of Florida for his addiction medicine fellowship. He is currently Associate Professor of Psychiatry and Addiction Medicine and Co-Chief of Pain Medicine at the University of Florida. His work has included serving as Medical Director of multiple addiction treatment programs, as well as expert witness work, consulting with state and federal agencies, authoring peer-reviewed works in pharmacological studies. Before we get started, there are a few housekeeping items to cover to help you participate more fully in the webinar. The tool we are using today is called GoToWebinar. The tool we are using today is called GoToWebinar. The GoToWebinar control panel you see on the right of your screen can be minimized and expanded by pressing the orange arrow near the top of the panel on the left. Doing this will allow you to see your entire screen during the presentation. You can also reopen it by pressing the orange arrow again. If you wish to download the slides for note-taking during this presentation, you can do so by clicking on the link in the handout section on your control panel. All attendees for this live broadcast are entered in listen-only mode. This means that your microphones are muted, so we will not be able to hear you during the presentation. However, you have the ability to send questions to our staff or to Dr. Jacobs through the questions panel during the presentation. Simply type in your question and click send. Hopefully, we will be able to answer all your questions before the end of the webinar. This presentation is being recorded and will be posted on the NACOA website at nacoa.org in a few weeks, where it will continue to be available to you in the months and years ahead. We will also send it to any requests received through NACOA at NACOA, NACOA at NACOA.org. If you are using your computer speakers to listen in today and are having trouble getting the volume higher, I recommend switching to a phone line. We seems to solve most problems. Simply check the telephone button in your control panel and follow the directions to make this switch. As you can imagine, we have a lot to cover in the next 55 minutes, and I am anxious to introduce you now to Dr. Jacobs.
Thank you, Sis, and thanks to NACOA and the great team that they put together to help make this an easy presentation for me. Here are my disclosures. I really don't have any outside conflicts. I am the Chief of Addiction Medicine at the Medical College of Georgia, as well as the Medical Director at Bluff Plantation Rivermend Health in Augusta, Georgia. So I start by sending you welcome and greetings from the great state of Georgia. This is the treatment center I'm actually sitting in right now, talking to you from, Bluff Plantation. We've been in operation for a little over 2 years here and have full service of residential treatment. Great place to live and work. I want to start with a little basic information about addiction to make sure that we're all kind of on the same level playing field, and then we'll move in the second half of my presentation to talk more specifically about opioids and the problems that we have not only in this country but worldwide. Dr. Nora Volkow, our great colleague up at the National Institute of Drug Abuse, has made the statement that drug addiction is a brain disease and that it can be treated. I think this is an important basic to know. We still fight the stereotype of drug addiction in this country, that somehow people who suffer from this disease are weak-willed, morally bankrupt, crazy, dumb, or stupid. And it's really not that. It's about having their brains hijacked. Certainly they do weak-willed, morally bankrupt, crazy, dumb, and stupid things when they're under the influence of drugs or when they're seeking drugs, but that's because their brain has been indeed hijacked. Now, this is a disease that affects every area of our population. Babies are born and having potentially been exposed to both legal and illegal drugs. The number of pregnant, opiate-dependent women that we're seeing in this country continues to climb, and as a result, those babies are exposed to that drug while in utero and are often born with physical dependence requiring that they be basically detoxified before they can go home from the nursery. It certainly can affect their later life. Adolescents certainly abuse drugs and often act out, do poor academically, and drop out of school. We also have a lot of down-the-line consequences like unintended pregnancies, violence, and infectious disease that affect this age group. And we'll talk more about adolescents in just a few minutes. Certainly our adult population abuses drugs and has cognitive problems, social problems, and work and personal relationships suffer. And then, of course, we know that addiction is a family disease, and certainly parents that have problems with drugs of abuse, for the most part, have very stress-filled and chaotic homes that frequently contribute to child abuse and neglect, and certainly this causes this to be a multi-generational problem that passes the problems down to the next generation, really sets the children that grow up in these homes at risk to become addicted in the future. So if we talk about drug abuse and addiction, we really need to define it and say what it is. And the American Society of Addiction Medicine has really defined this quite well. It's a chronic illness, it's a relapsing brain disease, and it's really characterized by compulsive drug-seeking use despite harmful consequences. It is a brain disease because we know that the drugs that have abuse potential change the brain. They change both the structure of the brain and how it works. And these brain changes can be long-lasting, potentially permanent. and they certainly do lead to harmful behaviors in the patients who abuse these drugs. It's important to remember that addiction is really a part of medicine, and it is similar to other diseases such as heart disease. They both disrupt the normal healthy function of the target organ, and if they're left untreated, can persist. This is a PET imaging from Dr. Volkow's lab at Brookhaven, and on the bottom of the screen you see a kind of a cross-sectional PET image of a healthy heart, and on the right you see a diseased heart, one that has suffered insult. And you don't have to be a neuroradiologist to be able to read this. Your scale is on the right-hand side. You can see that high areas of function, healthy function, are brighter, the more yellow and orange, and the levels of poor function are down in the green or blue range. If you look at the upper two panels of the slide, you can see on the left-hand side, a cross-sectional image of a healthy brain. And again, you don't have to be a neuroradiologist to look at that one on the right and see that the diseased brain, in this case of a patient with cocaine abuse, it has significantly less brain function, brain metabolism than the healthy one on the left. Now, I'm often asked, is continued drug use a voluntary behavior? And certainly the initial decision to take drugs is mostly voluntary. We do have those exceptional cases where perhaps someone has been kidnapped and perhaps is being sold as a sex slave and has been intentionally addicted to drugs. But for the most cases, the initial decision to take drugs is voluntary. However, after a certain amount of exposure of the drug to the brain, the brain is really hijacked, and the person's ability to exert self-control over their use is impaired. We know this because we can look at brain imaging studies from addicted patients, and we can see physical changes in the areas of the brain that are really important in terms of judgment, decision-making, learning, memory, and behavioral control. And these changes certainly that we can see physically in the structure of the brain also alter the way that the brain works, and they help to explain the compulsive and destructive behaviors that we see addicts exhibit. I find it fascinating that a lot of this was laid out in really what is the foundation for most patients getting into recovery, which is 12-step based recovery. They had very little knowledge of the brain anatomy and physiology at the time the prototype for 12-step recovery was introduced, Alcoholics Anonymous in the 30s, yet the more science we get, the more we find that it is catching up with the observations that were made in the Big Book of Alcoholics Anonymous. Now, in the DSM-5, which is the Diagnostic and Statistical Manual, 5th edition, which is sort of the psychiatry Bible for making diagnoses, psychiatric diagnoses, there are 10 classes of drugs, and you can see that opiates is one of those 10 classes. The way that the brain gets hijacked in both opiate addiction and in other addictions is through a process of neuroadaptation. Our brains are not static organs. Anytime we learn anything, we are changing our brain, and hopefully I'm changing some of your brains today as you're listening to me. We do develop actual changes in our central nervous system that occur, and particularly after a patient has continued to use a drug of abuse potential like an opioid, where they will develop tolerance and physical dependence, which would result in withdrawal symptoms if they were to either reduce the amount they were taking abruptly, stop abruptly, or take a agonist or a reversal type agent for that particular drug. Now, tolerance refers to either the need to use increased amounts of the medicine or the substance over time in order to continue to achieve the desired result, or if they simply do continue to use the same amount, they get a marked decrease in the effect that they're getting from that amount of the substance. Now, addiction is a developmental disease. I alluded to this earlier in talking about the adolescent population. It does typically begin in childhood or adolescence. The adolescent brain is not fully developed, and as a result, it is more vulnerable to the effects of any substances we put in there, particularly drugs that have a significant abuse potential. If you look at the progression from the left side of the slide to the right side of the slide, you'll see a sort of schematic of how the brain changes, and you can see the development of gray matter, that is more development of the blue shaded areas occurring progressively from about the age of 5 up through the age of 20, and that really correlates with our development and our progression out of the stages of childhood through adolescence and into adulthood. The adult brain is really not fully developed and fully mature until at least the mid-20s for women, and even a couple of years later for slow developing men. Now, addiction is a chronic illness, as I mentioned in the definition earlier. It has both biological and behavioral components, and both of those have to be addressed when we're trying to treat patients that suffer from this disease. It is in that way very similar to other illnesses and other medical conditions that all physicians treat. Recovery from it, which is really not just protracted abstinence from the drug of abuse, but also restoration of function, is really a long-term process that requires ongoing treatment. Chronic illnesses differ from acute illnesses, and I'll talk about that in just a bit. Relapses can occur both during and after initial phases of treatment, and really should be a signal to us that we need to either adjust, usually intensify the current level of treatment that we're providing. Certainly participation in support programs during and following treatment, as I mentioned earlier, the prototype for that would be 12-step based recovery programs, are really the key to sustaining lifelong recovery. So let's talk a little about how drugs work in the brain to hijack it. They not only produce pleasure, but they hijack the brain systems. We have a reward system in our brain that has developed to really emphasize to our brains what is key or salient or crucial for our survival as individuals, survival of our families, and even survival of our species. And there's a brain chemical called dopamine that's key to that system. So dopamine is the neurotransmitter that's present in a lot of areas of our brain that regulate both movement, emotion, cognition, motivation, and feelings of pleasure, and also, as I mentioned, feelings of saliency or importance. Overstimulation of this system in our brain, which was really designed to reward natural behaviors, produces euphoric effects in people who abuse drugs, and it really teaches them to repeat that behavior. So in that way of thinking, drug addiction, particularly with opiates, can be considered bad or maladaptive learning. So if we look at how does stimulation of the brain pleasure circuits or saliency circuits teach us to keep taking drugs, then our brains are wired to really ensure that we'll repeat life-sustaining activities by associating those activities with pleasure or reward. And whenever this reward circuit in our brain is activated, the brain is highly active, and it notes that something very important, crucial to our survival, is happening, and it needs to be remembered. And we're taught by the stimulation of this circuit in our brain to continue to do this behavior without even really having to think about it. And because the drugs of abuse stimulate this same circuit that naturally is stimulated by rewards that keep us alive, like eating when we're hungry, drinking when we're thirsty, procreation. For women, it's particularly involved in the nurturing of young, and for men, it's really involved in protection or sheltering of family units. The drugs that have abuse potentials stimulate this circuit in the same way and really hijack it. This is a kind of a schematic representation of a cross-section of our brain. To the left, it would be the front of the brain. You can see labeled as the frontal cortex, up where the eyes would be. We would be looking, facing to the left in this picture, and you can see really in the center of the brain, there's the dopamine pathways are in blue, and you can see in the very center of the brain, the ventral tegmental area, VTA, has a connection up to the nucleus accumbens. This is a dopamine pathway. This is the central component to that reward or pleasure pathway or saliency pathway in our brain. This is the area that is stimulated and reminds us to remember everything about what we're doing when we do one of those natural rewards that keep us alive. And it's also the area that gets hijacked by the drugs of abuse. So why would drugs that have an addictive potential be more addictive than these natural rewards that I've mentioned? Well, what happens is when these drugs are taken and they get into the brain, they release many more times the amount of dopamine than the natural rewards do. In some cases, this occurs almost immediately, particularly if a drug is smoked or vaporized and inhaled into the lungs or injected directly into the bloodstream. When drugs are smoked or vaporized, it's essentially needleless injection. We're getting the drug delivered to our brain and to that reward pathway in a matter of about 15 seconds. So these effects can be much longer lasting than the effects that we get when we engage in the natural rewards. So the resulting effect on this reward pathway or pleasure pathway in the brain is that use of a drug of abuse really dwarfs the effect that natural rewarding behaviors do. I think in terms of analogies, and if you use the analogy of this circuit like a light bulb, the natural rewards may light that pathway up like a 10-watt light bulb, whereas most of the drugs of abuse, particularly potent opioids like oxycodone, heroin, fentanyl, and others, light that reward pathway up like a 1,000-watt light bulb. So it's easy to understand then why those things taking, and feeling the effects of those drugs become more of a priority than the natural rewards do. And it motivates patients who take these drugs to take them again and again in order to try to get that feeling. And so, again, really, drug addiction, drug abuse is a maladaptive or dysfunctional learning system. Now, people often ask me, can addiction be successfully treated? And the answer certainly is yes. Addiction is a treatable disease. The discoveries that we've made in science over the last few years have really advanced the treatment and allow us to help people stop abusing drugs and resume productive lives. People often ask me, can a drug addiction be cured? And the reason is no, because it's a chronic illness. Addiction is a chronic illness. As I mentioned earlier, the difference between an acute illness and a chronic illness is we cure acute illnesses in medicine. If I develop bronchitis and my physician prescribes the appropriate antibiotic for me and I take it like I'm supposed to in the full dose, then the odds are that I will be cured from that infection, and I will not be at any greater risk to redevelop it, and I will not need to do any maintenance therapy in order to keep it from flaring up again. Now,
Dr. Jacobs?
Yes?
Go ahead.
Can you hear me?
I apologize. Yes, we lost your sound, but you're back. Thank you.
I'm back. Okay, thank you. I don't know what happened there. So, as I said, addiction is a chronic disease. It's not an acute disease. We have to continue to do maintenance therapy in order to keep the disease in remission. The analogy here is like diabetes. If I were to develop diabetes today and be admitted to the teaching hospital at the Medical College of Georgia, I might have to stay for a period of time, get my blood sugar into a normal range. But if I went home and did not do maintenance therapy, watch my lifestyle, exercise, diet, take my medicine like I was supposed to, check my sugars, go to my follow-up appointments, no one would be surprised if I either became ill and required readmission to the hospital or ended up dead. The same thing is true with addiction. We don't cure them. We can put the disease into remission, but it requires maintenance therapy to keep it into remission. It can be managed successfully like the other chronic illnesses. Treatment does enable us to counteract this hijacking of the brain that occurs and allow our patients to regain normal control of their lives. So another question I frequently get is, does relapse to drug abuse mean that treatment has failed? No. In all the chronic diseases, including addiction, relapsing is not a sign of failure. It's simply a sign of recurrence of the disease, which is always possible. Relapse rates for addiction really are similar to other well-characterized chronic medical illnesses like diabetes, hypertension, and asthma, all of which have both physiologic and behavioral components. Treatment of chronic diseases really involves not just taking medicine, but changing deeply embedded behaviors. Again, to use the diabetes analogy, if I develop diabetes and I don't watch my diet, lifestyle, exercise, that behavioral component, then it's unlikely that I'm going to be able to maintain my blood sugars in a normal range just with medication. And so for an addicted patient, a relapse to or return to drug use just indicates to me and other treatment providers that the treatment needs to be reevaluated and intensified. So if we actually compare the relapse rates between drug addiction and other chronic illnesses, you can see that in various studies, the percentage of patients who relapse after treatment for drug addiction is about 40 to 60%. If we were to call a diabetic who has their blood sugar rise above 200, then if we were to call that a relapse, then about 30 to 50% of the diabetics will relapse at some point. Same thing with hypertension. If we were to consider a patient coming into the doctor's office with their blood pressure above 140/80, despite their medicine, then we'd see that as much as 50 to 70% would be considered in relapse. And if, again, with asthma, if we considered a patient who was on maintenance medicine but ended up in an emergency room requiring a breathing treatment of some type, you can see that the relapse rates would be about 50 to 70%. If I can, there we go. So, what are the principles of effective addiction treatment? Well, research has shown us that combining treatment medications when they're available with behavioral therapy is the best way to ensure the success for the treatment. And in the area of opioids, we have specifically come up with several medications that can be effective when combined with behavioral therapy and increase the success rates for our patients. But treatment does require that we tailor the approach to their patterns of drug use, as well as their co-occurring medical, psychiatric, and social problems. And so, when I'm asked if medicines can help to treat drug addiction, yes, they certainly can help in treating the withdrawal syndromes. And although opiate withdrawal is not typically life-threatening, our patients who are suffering severe opiate withdrawal will feel like they're dying, look like they're dying, tell us they're dying, but they don't die. But they still need to be treated medically in order to enable them to be able to do the treatment work to get and remain sober. So we need to get them detoxified from the drugs so that we can initiate the real treatment. Detox is not really treatment. It prepares patients for treatment. And this is a beautiful picture of the opium poppy. It's one of the prettiest plants in nature, but it really has caused us a lot of problems over the years. It's popped up in some of our classic movies. You can see the huge poppy field there between Dorothy and her colleagues en route to the Emerald Kingdom. And in the mid-1990s, we had the release of OxyContin, which was a controlled or sustained release oxycodone formulation in this country. And that for the first time, we had single doses of medication which were significantly greater than anything we've had in the past. Prior to this time, most of the doses for oxycodone in a single pill were at a maximum of 10 milligrams, which, as you can see here, was the smallest available OxyContin tablet. And at the time of its release, there was a formulation that contained up to 160 milligrams, which would be the equivalent of 16 Percocet tablets at the time. Now, that dose formulation has since been removed from the market, but we still have doses of up to 80 milligrams. Methadone has also been rediscovered primarily by the pain physicians in this country, and is an extremely potent synthetic opioid that does have a very long half-life in the human body, and with repeat dosing will accumulate over time, and that's one of the reasons that we see such high overdose rates with methadone, because a patient will take a dose and feel an effect and continue to repeat dose over time with the methadone levels accumulating in the system until they reach toxic levels, resulting in respiratory depression and death. And then, of course, we have the illicit opioids. Here on the top panel, you can see various preparations for heroin. In the middle, China White was the heroin that we had seen for years in this country, primarily coming out of the Far East. The black tar heroin and the brown heroin that you see on the left and on the right have been coming primarily out of Mexico, and because of their production and marketing strategies, have developed significantly higher potencies. And then we have the pain medication, fentanyl, that you can see as in the injectable form used primarily in the operating room, as well as the transdermal delivery system for fentanyl, the pain patch on the right-hand side, which have been used to treat chronic pain in this country since the mid-90s. And a fentanyl analog that has recently been in the news, carfentanil, is a veterinary anesthetic agent, and you can see in this depiction that this is primarily was designed to be used in large animal veterinary practices, and where you have an elephant that may weigh up to 14,000 pounds, but when a human who weighs an average of 195 pounds takes that, they're looking at something in the order of 72 times the weight. And on the right-hand side, you can see sort of a comparative strength of opioid painkillers, with hydrocodone and morphine being listed as a standard strength of 1. And you can see heroin is 4 to 5 times more potent, with fentanyl being 50 to 100 times more potent, and carfentanil, which is now coming into our market illicitly from out of the country, at potentially about 100,000 times the potency of hydrocodone. Now, how do opioids work in our brain? Well, they bind to mu opiate receptors in our central nervous system to modulate pain, and they cause certain things to happen. They can cause intoxication, and you can see the signs and symptoms there with pinpoint pupils, sedation, constipation, slow heart rate, lowered blood pressure, decreased respiratory rate, and if the doses get high enough, respirations can actually stop, and then cardiac arrest and death. The treatment for this intoxication or overdose syndrome is simply supportive in terms of rescue breathing and giving the opioid reversal agent or antagonist, naloxone. In patients who have developed tolerance and physical dependence, when they stop taking the medicine or abruptly cut down on their use of the drug, they can go into withdrawal, which, as I said earlier, is not usually life-threatening, but can be extremely uncomfortable, and you see the opposite signs with dilated pupils, runny eyes, runny nose, diarrhea, body aches, and agitation. And this can be symptomatically treated with a specific agent, clonidine, which is a old blood pressure medicine, but also treated with medications to target the particular symptoms. This is a depiction of the Narcan or naloxone nasal spray, which is available to help reverse opioid overdose. In the past, this medication had to be given by injection, and so it was difficult to get into the hands of first responders like policemen or firemen, as well as some of the EMTs. Now that we have this available as a nasal spray, it can be prescribed both to pain patients who are on high doses of opioids and are at risk, to addicts who are trying to get and stay in recovery. In the event that they do relapse, they can be resuscitated, or to family members who may have a loved one who they fear for overdose. Now, let's talk a little about pain, because without our change in our philosophies and treatment of pain in this country, a real shift in a paradigm for the treatment of pain, we wouldn't really have the opioid epidemic that we currently have today. Pain is really an unpleasant sensory or emotional experience, and that's the key word here. It's an experience. When I teach my medical students about examining a patient and taking a history on a patient, we talk about signs and symptoms. And symptoms are what the patient tells us, but signs are what we can actually see or measure on the patient. And pain is really a symptom. It's not a sign, even though it has been declared the fifth vital sign and required to be tested and documented in hospital patients, unlike heart rate, breathing, and temperature, which are signs that we can objectively measure, that we don't have any real accurate pain meters which we can apply to a patient and get a number. We have to ask them what their experience is in order to get an idea of what level of pain they're in. Now, acute pain has been considered pain that lasts for less than 3 months, and chronic pain has been really, initially when I trained, was considered pain that was persisting for greater than 6 months, certainly after the standard healing should have occurred after an injury or a surgical procedure. We've recently, in the last decade, shortened that time frame to about 3 months, but it still really should be considered when the injury or surgical procedure would have been normally expected to have healed. And we've certainly seen an increase in opioid prescriptions. Drug distribution of licit legal drugs in this country has increased dramatically. In 1997, we distributed about 96 milligrams of morphine equivalents per person during that time frame. But by 2007, we had actually increased that up more than 7-fold to 700 milligrams per person for the year. 600%, greater than 600% increase. And if we look at this graph over the time frame from about 1999 to 2010, we've seen that in the green line, as opioid sales have increased, we have a parallel increase in the opioid deaths and a parallel increase in opioid treatment admissions. And that certainly has continued on the same trajectory, all three of those lines, for the next few years up until the present. Now, if we look at overdose deaths, this is graphed number of deaths per 100,000 in the population over the time frame of about 2000 to about 2014. You can see that we, in this country, have had a steady and very significant rise in the number of overdose deaths that are involving opioids in the top line, and the natural or semi-synthetic opioids, those would be opioids like morphine or hydrocodone. In the second line, the large hash marks, and then you can see methadone and heroin all trending up, with the synthetic opioids in the kind of combination of long hashes and short hashes down at the very bottom, turning up dramatically about 2013. So if we think about how effective are the pain medicines that we have available, the Cochrane Review is considered a standard in medicine for patients, for doctors to look at in terms of determining the effectiveness of a particular treatment for a particular condition. And if we look at the percentage of patients that get 50% pain relief, which would be pretty significant pain relief, I certainly believe that if I had a broken leg and was taken to the emergency room and they gave me pain medicine that reduced my pain by 50%, I would find that to be significant. And if we look at the different effects of various options that we have for treating pain in terms of getting 50% pain relief, you can see there that 2 5-milligram Percocets, kind of what had been our standard before the mid-1990s, would give about almost 40% of the patients 50% pain relief. Ibuprofen with 200 milligrams would give about the equivalent percentage of patients significant pain relief. Ibuprofen 400 milligrams, which would be a standard over-the-counter dosage of 2 ibuprofen tablets, gets us up to that 40% mark. Interestingly, oxycodone 15 milligrams, which would be 5 more milligrams than the Percocet, which had a combination of oxycodone and Tylenol in it, only gave about 20% of the patients significant pain relief. And if we look at Tylenol, it's actually by itself better than 15 milligrams of oxycodone. This is really contrary to what most people and actually most healthcare providers have been led to believe over the years. And if we actually look at the combination of ibuprofen and Tylenol, you can see that more than 60% of the patients will get significant pain relief from that dose, and it is clearly almost twice as good as 2 5-milligram Percocets. And if we look at renal colic or kidney stone pain, which is considered by most people to be one of the most painful conditions you can have, in a 2005 Cochrane review, they found that non-steroidal anti-inflammatory medicines like ibuprofen or naproxen, and when compared to the opioid pain medicines, were equally effective in treating that pain. But the opioids had many significant side effects, including constipation and potential for overdose death. As a result of the significant increase in prescribing and the associated overdose deaths and admissions to treatment centers for opioid addiction, in March of this year, the CDC proposed some guidelines to help doctors rein in the likely overprescribing of opioids. And these included, considering other options, and as well as not prescribing them unless the potential benefits clearly outweighed the potential harm, and that we should try to use the immediate release rather than the sustained release opioids when we start therapy for chronic pain. We should certainly use the lowest doses that are effective, and if they're prescribed for acute pain, they should be prescribed for short periods of time, usually 3 days, rarely more than 7 days. We also now have state prescription drug monitoring programs that healthcare providers can access to see what controlled substances our patients may have obtained from other providers. Also suggested in the guidelines is the use of urine drug testing both before and during treatment with a controlled substance like an opioid, to be sure that our patients are taking what we are prescribing them, as well as trying to identify patients that may be taking other controlled substances or illegal drugs, and that we should be able to get these patients into treatment if they have developed an opiate use disorder, which is clearly a risk for any patient that we give these medications, these opioid medications to, even if they do have legitimate pain. So in light of these guidelines and the recommendations that we rein in our prescribing and try to reduce the amount of opioids, a lot of people have been tapering and reducing the amounts of opioids that patients have been getting. And there's been a great deal of concern about, is this going to cause harm to our patients because now we would be potentially under-treating their pain. Well, it's very interesting, both in this study and in my clinical years of 30 years treating patients with both chronic pain and addiction, that an opioid taper in patients on chronic opioid therapy actually resulted in an average pain decrease rather than an increase. So getting them off the opioids actually improved their pain by about 24%. And although about half of the patients did end up going back on opioids after this taper, however, their pain wasn't improved even when they went back on the opioids. So a taper to off of chronic daily opioid therapy has been shown to reduce pain in all age groups, at least a 20% reduction, and it also helps reduce the amount of depression that our patients that have chronic pain suffer, as well as what we call pain catastrophizing, or the worry or fear of even moving that these patients develop. So what is the treatment for an opioid use disorder? Well, chemical dependency treatment involves, as I mentioned earlier, medical detoxifications to get them ready and able to actually do legitimate treatment work. It involves support and containment of their illness to when necessary, keep them in settings where they have less access to their drugs of abuse. It involves a lot of education, but it's more than education. It involves skills building, as well as psychiatric and psychological support. And of course, 12-step recovery has been one of our strongest foundations for both getting patients into recovery and keeping them there. We also have 3 medications that have been useful in helping treat opioid addiction. These medications are not in and of themselves cures. We have methadone, which is a substitute for the opioids that you're using. Long-acting opioid can be used as a substitute. We have buprenorphine. The most common brand name would be Suboxone. And then we also have naltrexone, which is an opioid blocker, which can help turn down craving for opioid, reducing risk of relapse. And it can also provide protection if the patient does relapse by helping prevent overdose death. So again, the naltrexone is a blocker. It can be taken orally or by a monthly injection, which makes it very nice because it takes the daily compliance out of the equation, and it does provide a much more steady blood level. We have methadone, which can be administered in certified federally and state licensed opioid substitution programs. And then we have buprenorphine, which is only a partial activator of the opiate receptor and has a ceiling effect so long as it is not combined with sedatives like benzodiazepines or alcohol. And this can be prescribed out of a physician's office, not necessarily out of a licensed clinic. And so I'd like to wrap up my talk here by recommending a couple of books that I think would be very helpful for the faith and lay community to review. Dreamland, our drug czar, Dr. Botticelli, has indicated that this was the most important book published in 2015. It really details the development both of the black tar heroin distribution from the Mexican southwestern states spreading across this country, as well as American Pain, which is a story of the one of the first and largest pill mills in South Florida. And with that, I'll wrap up and hopefully leave a little time here for questions. Thank you for your attention today, and again, thanks to NACOA for allowing me to present this for you.
Thank you, Dr. Jacobs. That was terrific, and it was so informative. For all the participants on this webinar, let me extend our deepest thanks. The insights and the information you've shared today with such clarity is a great gift to all of us, and especially the people working in the faith communities who are trying to provide solace and support to individuals and families impacted by addiction. And yes, we have time for a few questions, and we have quite a few of them. The first question is, what educational programs would you recommend for people in our average congregations? Programs that we who are working in congregations can offer to our people.
I think that there are a couple of really good sources for that. You know, one of the sponsors for this presentation today is SAMHSA, and SAMHSA has a very exhaustive website that has a lot of educational material on it. The other two sites that I think are particularly good are the National Institute of Drug Abuse, the NIDA website, which actually has PowerPoint presentations that are designed and could be easily downloaded and presented to members of your faith community by a lay person with interest. The other site that has a tremendous amount of information and is frequently updated on the status of drugs coming into this country, especially these newer opiates, the carfentanil and other synthetics that are coming in from apparently from China at this point, would be the DEA's website.
And that would be DEA.gov, and that would be NIDA.gov. Thank you for that. You mentioned about protracted abstinence and restored functioning is often a long-term process requiring ongoing treatment. But how can we support people in our congregations who are hooked on drugs and their families when insurance only covers a portion of treatment, sometimes only a few days or a week?
Yeah, it's a struggle I fight with on a daily basis because I'm not just a medical educator. I'm a clinician at a treatment center, and I think we need to continue to work, with our representatives on both the state and national level to increase funding for treatment, as well as prevention. Sometimes we forget about prevention of this disease. It is so much more effective, both from a cost and from a social standpoint, to prevent the development of addiction than it is to treat it. But again, we do have ongoing support from the 12-step communities, Narcotics Anonymous, as well as Celebrate Recovery, which a number of the faith communities are hosting those meetings on their local sites with great success. I can tell you I have a lot of patients that utilize that as their ongoing support for their recovery.
Often we get a parent who's really worried about a teenager using drugs or drinking, especially a parent who's married to an alcoholic or a person who's a drug abuser. And what would you tell that parent? Because you're talking now about the high risk, the kids who are more high risk for addiction when you're talking about the kids.
Well, I think the first thing is not to ignore it. If you usually where there's smoke, there's fire, and if there's a suspicion of drug use that may not have developed into full-blown addiction at that point, it still needs to be addressed. And one of the best ways to address that is to work with the primary care providers, whether it's the primary care physician, the pediatrician, or local counselors.
A question about Narcan. Do you recommend that faith communities keep Narcan or naloxone on hand in case of emergencies?
Absolutely. More and more states are now passing laws allowing groups or individuals to be prescribed this by physicians in their area, and it could be kept with just like you have a first aid kit. We have had discussions with this. Some of my more conservative colleagues have opposed this, saying that it's going to encourage patients to use more opioid. And my response is, if they're not breathing, it's impossible for me to treat them. And a number of these patients will overdose and die before the professionals can get there, the EMTs, 911 can get there for help. And it's very simple to administer with simple rescue breathing to support it, and it saves lives. The risks are extremely small in having it and using it. And most of the states now that are passing these laws allowing groups or individuals to have Narcan available. Also pass parts of that law that provide Good Samaritan protection from criminal or civil action.
And you know, on that note, we've reached the end of our time. We have several more questions I'm sorry I couldn't pose for you. But thank you very much, Dr. Jenkins. This has been terrific, and I think your suggestions to help people working in congregations can be extremely helpful.
Well, thank you. It's been my pleasure.
To all of our attendees, when we conclude this webinar, would you please look at the viewing window in your screen. A new window will pop up automatically where you can give us some feedback about the presentation. Please take a few moments to do that. And thank you all for coming.